Hello, everyone. My name is Corey Thornton, GM of the Open Minds Market Intelligence team. Welcome to today's Circle Elite Roundtable, Behavioral Health Urgent Care, the Kidspeace case study. Today, we are featuring the great speakers of Chris Ferry, Executive Director of Pennsylvania Community Programs and North Carolina Residential Services at Kidspeace, Kate Peterson, Director of Healthcare Network Project Management at Alliance Health, and Tammy Margson, Program Director at the Hope Center for Youth and Family Crisis. Before I hand it over, I have a few housekeeping reminders. Your audio will be muted for today's briefing. However, we encourage you to submit any questions you may have using the question box located at the right side of the screen. At the end of the session, we will answer those questions live. And finally, the slides and the recording for today's roundtable will be archived and available for elite members on the Open Minds website. And with that, here is Chris Ferry to start us off.
Thank you, Corey. Thanks for having us. We're excited to be here. I'm going to give a brief little background of Kidspeace, the organization that I work for. I've been at Kidspeace now for 25 years. And Kidspeace has been around since 1982. Our mission is to give hope, help, and healing to children, adults, and those who love them. We have a large array of programs, including residential treatment programs, accredited educational services. We have a 120-bed psychiatric hospital, which is in Orfield, Pennsylvania. We have foster care throughout the Pennsylvania. We're actually in 7 states in foster care. And then we have community-based programming in Pennsylvania. That's what I directly oversee. Currently, we provide services in 7 states, and we receive referrals from over 39 states, including the District of Columbia. Since our doors opened, we've worked with nearly 300,000 children and adolescents in need. The PA community programs, which I oversee, provide services to over 5,000 consumers annually. It consists of 3 partial hospitalization programs. Those are intensive day treatment programs, 6 hours a day, 5 days a week, children and adolescents, ages 5 to 18, so basically 1st grade to 12th grade. There's also 5 autism-specific programs that serve individuals between the ages of 2 and 21, and those services are provided either in the home or back at a location. And then we have traditional outpatient services. We have 4 clinic sites in Pennsylvania where we have over 1,200 children, adolescents, and adults that we have in care. We're working with consumers ages 3 to 65, providing individual, family, group medication monitoring. We do obviously site-based, but then we also offer telehealth services at these locations. And then new to Kidspeace is what we're going to talk about today is our North Carolina project. And there's 3 programs here at North Carolina that we're going to be up and running soon. One is actually already running. We have a facilities-based crisis, which is the FBC, a behavioral health urgent care, BHUC, and a MORS team, which is a mobile outreach, response, engagement, and stabilization. These are designed to provide assessment, stabilization, and treatment to children and adolescents in crisis. The MORS team, which is currently functioning, is a team of specially trained crisis responders who address immediate crisis and connect families to community resources. So they're getting called to go to the homes in need and provide this service. The 2 other programs which are going to be opening soon is the BHUC, which is an alternative to emergency departments, where children and adolescents will receive up to 23.99 hours of clinical observation, case management, and placement assistance. And then from there, these children and adolescents can transition into an FBC, which is the facilities-based crisis. And this is a 16-bed short-term inpatient crisis center with a focus on mental and behavioral health stabilization for children ages 6 to 17 years of age. So we're excited about these services. I want to give a little background and ask Kate to talk a little bit about Alliance.
Alliance Health is a managed care organization. We do Medicaid managed care and work with uninsured in 6 counties of North Carolina. And it covers Cumberland, Johnston, Mecklenburg, Orange, and Wake counties, which covers Raleigh, Charlotte, Fayetteville, a lot of our higher population centers. In April, we actually will be providing integrated and whole health care and managing physical health and pharmacy for some of our, it's known as a behavioral health IDD tailored plan in North Carolina. We have been around since 2013, and in 2015, I had joined Alliance. I had been previously a service provider, and we began to look at models of crisis programming for adults because we wanted to do some more evidence-based crisis management. So I visited every facility across North Carolina and then some. And our research led to a model that we settled on, which we have been utilizing in our adult crisis programs. But during that time, what struck me is that we weren't really doing anything for kids. We were assessing them in the same places that adults were. We were really struggling with what happens after assessment. It seemed to be an issue for us. So that really sparked some conversation internally, and we'll talk about that a bit. We were given a grant opportunity in late 2016, and that was to develop a facility-based crisis center for children. And in order to apply for the grant, we had to have a selected provider partner apply with us. And so we did an RFA, and through that process, Kidspeace was selected. We very intentionally wanted an organization that had a lot of experience with kids and families.
And we had also been known to you down in North Carolina with the 2 foster programs that we have in Fayetteville and Raleigh.
And so you can go to the next one, Chris. We were awarded the grant in early 2017 and began a property search. And we geomapped where all the kids were coming from, to the emergency rooms, to our crisis center in Wake County. And we weren't covering Charlotte at that point in time. Charlotte joined our array. Our Mecklenburg County joined our array a little more than a year ago. So we really looked at where these kids were presenting and where they lived. And most were within an hour of southern Wake County, south of Raleigh. And Wake County is a pretty good size, besides having Raleigh, which is a pretty good size population. Wake County itself is 844 square miles. So it's a pretty large physical space county. It covers a lot of area. The local hospital system actually had an old rehabilitation center that used to be a community hospital, and it was in southern Wake County. We had looked at it a couple of years before in 2015, when I remember we were talking about adults. We actually looked at this particular building. It was empty, and it's on the end of a dead-end street, had 5 acres of land with it, but there was no way to easily get there for adults that didn't have transportation on their own. Kids come with transportation, and at that point in time, we kind of said, if we ever have the opportunity to do something here with children, this would be a good location. So we actually ended up going back there when we started our property search, because it was in the right location and it matched up with the geomapping, and our local hospital system sold us the property, and they were very motivated to get our kids out of the emergency room. So it all fell together pretty well. So, but the building needed extensive reno, and right down to mold and asbestos. So there was a lot of moving parts to this. We needed every bit of the grant to be able to do the renovation. You can go ahead, Chris.
So the
So,
problem
yeah.
identified by Kate and Tammy, right? So go ahead, Kate. You were just talking about the
Yeah, I
need.
was just going to say that I talked a little bit about this. We really saw children assessed in facilities that were really designed for adults. They really weren't designed for kids and families. There was potential for youth harm and adult harm given space and staffing. I walked into one place where I saw in one facility, not one of ours, but I saw one where there was a 70-year-old in the same physical space being assessed as a 15-year-old. And that is not a great situation in any stretch of the imagination. So we really had a lot of internal discussion about this, and that is what led to us getting out there to find the grant, to be looking for space. And we worked with Kidspeace closely, and Tammy was identified by Kidspeace as the director, and I said from the get-go she was the trifecta because she had history working with children and families. She knew North Carolina Medicaid, and she had run an adult crisis program with a lot of similar elements to what we wanted for children and families. Tammy, you got anything to add to that? Because we've worked really closely together.
I do. I mean, I had been working in adult crisis services here in North Carolina since 2008, and saw the success that this model that we're developing for the Hope Center had with adults. I knew that it worked. I knew it was trauma informed. I knew it was least restrictive. It was as close to home as you could be without being there. You were supported by people who understood what it was like to have challenges with mental health and substance use. I also knew what it was like as a clinician and a director to try and assist our local emergency room directors and doctors in finding placement for a 14-year-old who had been in their ED for 12 weeks without any disposition. And so I knew how much this service was needed for our area and for our kids. And with COVID setting in shortly before me coming to Kidspeace and watching the mental health of our children decline, it just became more urgent. And it's been quite an adventure, and I'm excited to get it off the ground and start providing services to our kids.
Yeah, I know in Pennsylvania where I'm at, the EDs are just unequipped, and these children, are sitting next to other people who are there with physical health concerns, and often 8 to 10 hours is an easy day, and then they're leaving without a recommendation. I mean, I'm working on a case, or I was working on a case right now with a local children and youth provider where a kiddo has been sitting in the ED since October, and just being housed there, and he's got autism and a lot of behavioral issues, and there's no place for him. So I just think like this program would have been a great fit.
And in defense of our emergency rooms and the professionals that work there, I mean, they're very well trained to address the physical health of a human being, but it's not the setting to address someone's emotional and mental well-being. There are patients in there with broken bones, and they're screaming and they're hollering and they're bleeding, and you have a traumatized individual, whether it's an adult or a child, sitting there who's already emotionally unwell, and they're not going to receive the support and intervention that they would in a behavioral health urgent care. And this model I think works really well because it's a combination of both the urgent care and the facility-based crisis. And then, as kind of an afterthought, we opened the Morse program first. And that's a program that can come and do a crisis assessment in the home with the family and make a recommendation about what the next best step is. And if the next best step is to get a clinical evaluation and have a licensed provider put their eyes on this kid, and we'll have the place to do that as well, where in the past we haven't. So yes.
Yeah, I do want to say something about Moore's. It is based on the MRSS model out of Connecticut and New Jersey and in many other states across the country. And I was watching that program develop in another part of our state and said, you know, this is something we really need to look at. And then the Center for Innovation released a report to the states on effective crisis programming for youth and families. That was in that report. And at the time, we actually made a decision in 2020, before I think the pandemic actually hit, that we were going to roll that out in all of our counties. And so we had started in Cumberland County, and then with Kidspeace, the facility being delayed due to construction issues and COVID and a myriad of those kinds of things that we couldn't control, we said, well, you know, we're going to get this off the ground anyway, and you've got now your infrastructure built and ready to roll. Why don't we have you guys start up this type of program? And truthfully, if you look at some of the more recent, the guidelines for crisis continuum for children and families that was just released from SAMHSA a couple months ago, there are 3 main objectives in that, and we're hitting all 3. It's a warm line, which of course 988 can serve as that, and we have a call center as well. And then a quick response for children and families, and so Moore's does that. And the teams include a family partner, which makes it even more more powerful. And then 3 is safe places for kids to be. And so the FBC was part of that. But you also need a really good assessment to know where you're going. And so the BHUC served as that. And talking about performance data, we actually took, a look at the urgent care models in physical health care and kind of patterned after that a couple of programs that had longer hours and could serve walk-in behavioral health crisis, very much modeled after, an urgent care that you would go get an x-ray at. And what we saw is that there was great success there in diverting people from hospital. And about 80% would report after their visit that if that service wasn't available, they would have gone to the emergency room. So, and so that was really the pattern that we wanted to use for the behavioral health urgent care for kids and families. And so we wanted a quick time for assessment to happen. So we want people available to assess as quickly as possible. We want law enforcement and EMS to have very short drop-off times. One of the successes of an adult provider that we have, RI International, is they pride themselves in keeping drop-offs under 5 minutes. And that's huge for success of the program in the community. We want as many voluntary admissions as possible and involuntary admissions converted to voluntary wherever we can, because we want people to willingly want treatment. We want them to be engaged. We don't want to be really forcing. We really want to work ourselves into engaging. So how much did this cost? It cost a lot more than it probably should have, because we got a lot of delays during COVID. So we had, because we are a quasi-governmental agency, one of the things that we have to live with is public purchasing rules. And we had to go with the lowest sealed bid. And we did go with the lowest sealed bid, and the contractor could not complete the job. So we had one contractor switch to another, have had all sorts of supply chain delays like everybody else has. So we're talking about a $12 million investment, all things told. And part of our investment was to keep the infrastructure going with Kidspeace so that when we could finish, we could open quicker and not have to back up. And so that's been another investment that we've made.
Absolutely. I just commented today in another meeting about the fact that setting up programming like this is no small lift. There's not an agency out there that walks into a process like this blindly, not expecting to spend millions of dollars out of their own budget. And the partnership that we've built with Alliance to support Kidspeace through the startup of this facility has been above anything I've ever experienced with any other MCO. I don't think that it would have been possible for Kidspeace to engage in this without the kind of support that Alliance has given us. We began hiring our staff for the facility in the late winter, early spring of last year, and Alliance has funded payroll for this with the facility not even being open yet. The behavioral health urgent care will be staffed 24 hours a day, 7 days a week with registered nurses, licensed clinicians, mental health techs, qualified professionals, on-call providers, 24-hour contact with licensed clinician and licensed clinical addiction specialists, who unfortunately is me. And just to provide a safe environment for families to bring their children. And honestly, the outcome is to reduce the number of kids that are presenting in hospitals for behavioral health assessment. The average length of stay that we're expecting for the behavioral health urgent care, of course, is less than 24 hours. But in the facility-based crisis, the expectation from the state is up to 2 weeks. What I've seen typically in facility-based crisis services is best case scenario. The average length of stay is typically half of that. And the goal is always to provide a discharge where the youth and family will be supported with outpatient services or the appropriate level of care after discharge within 7 days. We will utilize our Moore's team as part of that process to help ensure that the family gets to their next level of care appropriately and gives a level of support that helps ensure that we won't have repeat customers as often as many places do. Hopefully, we shall see.
How many staff total, Tammy?
At this point, we have a total, including management, of 48. After we hire for the facility-based crisis, we will have approximately, with the Moore's team, 100 to 105 personnel.
Yeah, so it's not a small operation. Both programs of the urgent care and the facility-based crisis are distinct programs. So there's some of the staffing has to be distinct.
Yes.
And the facility-based crisis, of course, since it's full 24-hour care, is licensed as a subacute facility in North Carolina, and then the urgent care is treated as an intensive outpatient type of program. So for the purposes of Medicaid insurance, which one thing that has been helpful as we were able to get an in lieu of service definition with Medicaid to cover the behavioral health urgent care, because there wasn't a definition for that. And so having that gives a bundled assessment rate to the provider, so it's pretty reliable, and it assumes there's going to be some stabilization time, and kind of hits in the middle there. If somebody's staying a few hours, there'll be those that stay the full 23.99. There's going to be those that you can really do a thorough assessment and get them out in 3 and 4 hours. So it's, just depends on the situation. And we're going to learn. This is one of those projects that we have just, really put together thoughtfully, but like most projects, there will be lumps and bumps along the way. And we may learn some things that we will change as we move through this process. So.
And it's very likely that a child and family will be engaged at the start from the Moores team and move through that continuum of care and then back into the Moores team for ongoing support until other services get involved.
Yes.
Yeah, and Moores is definitely designed, and if you know anything about the MRSS model, it's definitely designed as flexibly, so the team can do some stabilization over, up to 8 weeks. They can respond immediately in crisis. And unlike the mobile crisis teams that we typically have in North Carolina, they're more adult centric. This is really child and family centric, and really focuses on the family dynamics piece of this and supporting the family. So,
well, not only that, but they also provide a level of case management and connection to services that's not provided in adult mobile crisis services. They make telephone calls, they attend family treatment team meetings with the parents and things like that while we're working to get the child connected to care.
Which I think is huge because, it's a tricky environment. If you're not working in the mental health environment, it can be overwhelming. What do I need for this assessment? How do I get this level of care? Do I need a doctor to prescribe this? Do I need, will my insurance cover this? So there's a lot of things that the Moores team can do to help educate and help folks.
Yeah, definitely. One thing that I think that, just to go back a little bit, if I knew then what I know now, timing. The timing was horrible. I just can't say that enough. I mean, imagine having a facility that needs incredible renovation. Basically, we were taking a 28,000 square foot building that was built in the 50s down to the studs and rebuilding it using the same footprint. Only we had mold, asbestos, and turkey buzzards that were living on the roof. So that would follow you around as you walked around the building. So if you can imagine that, it literally would have been the best haunted house in for any community. So we wouldn't have timed it this way if I knew then what I know now. We would have hired a separate construction manager, because I think we were using a combination of our architect, construction management, and our internal. And I think what that would have helped with is some of the things that caused some delays in materials and those kinds of things. I think you could have gotten a little different creativity. I say that not being a construction person, I'm really a program person. So somebody in construction might think that differently. Advice to others, it's going to take longer than you think. I think.
I like that one, Kate. I mean, when I came on with Kidspeace, I can remember during the interviews in late 2020 being told we're opening next June. and I am a construction person. Before I came to this life as a clinician, I worked in construction, and I said before I ever walked through the facility door, no, you won't be. And then I walked through the door and I went, no, this is going to take a while.
It is. So Tammy, one thing that, do you want to talk a little bit about the assessment tools and process? Like, because there's a pretty detailed assessment.
There is. I mean, from start to finish, mom and dad walk through the front door with their kiddo in tow, whether they want to be there or not. And they're greeted by admission specialists at the front door who will do a brief triage with them and maybe you know, a very off the cuff, as parents would say, suicide screening, and then take that level of triage to the clinicians on the floor and engage the family with a family partner, someone who's been there and done that the same as their parents, and help them to understand what the process will be. Then they'll meet with a clinician and a registered nurse. They'll have a full physical health screening. They will have a full crisis assessment done by a clinician. And then the clinicians will staff the case with the provider that's on duty and make a recommendation for whether what are the next steps? Do we keep the kiddo for a few hours and observe them, check their medications, make sure that they're stable and safe to go home? Do we hold on to them and possibly refer them to inpatient stay somewhere if they're a danger to themselves or others? The provider on duty within 24 hours will do a psychiatric evaluation if the youth remains with us, and move forward from there. Once they're in facility-based crisis, should they transition there, then they can look forward to ongoing support from clinical staff, one-on-one therapy sessions, group therapy, whenever possible, depending on the population that we're serving that day. And just an environment that is safe, someplace where they can engage with their peers on the unit, someplace where they can be supported by professionals who are trained, have complete clinical assessments done, have medications evaluated, changed, stabilized before they move on to hopefully go home where they belong, or to the next best place.
I think one thing that's different about the urgent care too is that you can prescribe, and that's really important, because I think a lot of families and children could benefit from medication therapy, and and a lot of times they have to wait weeks and weeks and weeks and weeks. And
they do. And there is a serious lack of resources for referral to outpatient services. And a lot of times it's based on the insurance or lack thereof. What we've done over the last, in my case, 2 years, is work to build relationships with providers in the community. I have relationships with prescribers who specialize in youth. In fact, I just had a discussion yesterday about whether or not that person's practice was equipped to accept hospital discharge appointments, and the answer was a resounding yes. And for a facility like this, that's huge.
It is. So I think, yeah, I think we are trying to ensure we're thinking through everything from beginning to end. And our biggest challenge is going to be discharge planning and having enough resources available immediately for children and families as they leave. For that very reason, there's we are a resource-rich area, quite frankly. because we are more urban, there is more available. But even with that, we have seen more acute situations, more families needing services, more social drivers needing to be in place, food security. Yeah, it's just food insecurity and housing insecurity. And so that's really our biggest challenge, I think, as we move through this. Great.
Thank you very much, Tammy, Kate, and Chris. We have a few questions we'd like to work our way through, and you touched on some of these questions, but we'd like to go ahead and pose them anyhow. You know, for an outside organization that's looking to replicate a program like this, what's your advice going into this process?
Well, I think you've got to be realistic about the investment. It's not you're not going to get a real quick return. We are spending, though, a lot of money supporting children in short-term crisis beds across our catchment that probably will not receive as good, as thorough an assessment as they could at this facility. So, perhaps the outcomes will look a little better. So our ROI will start to come back to us, but it takes a lot of money. I mean, right now, like I said, we're in $12 million. And I think we won't necessarily gain that back in, I think it's going to be 3 to 4 years before we see that back. Any sort of real return on that. It's just going to take some time. I think the only thing I was going to say, the one thing that's beneficial is the ongoing operation can be paid for by Medicaid. So we actually, it's the upfront costs that are the biggest costs moving through the process. That insurance will cover our members. So.
Okay. You guys spoke quite a bit about working with provider organizations in the community. When you're looking at another organization to work with, what are you searching for? Somebody who sees what you guys are doing and say, this might be an opportunity. I have some value to add. What are you guys looking for to start that conversation?
The number one thing I, as a director, look for in working with other agencies as referrals resources is the level of expertise that that agency has, whether or not they can provide adequate services to the children and adolescents that we serve. I work with my MORS team right now in discharge planning and service planning, and it's based on the needs of the family and what the family wants. But I'm not going, for instance, I'm not going to refer a youth with autism spectrum disorder to someone who specializes in trauma-informed care or PFCBT. I'm going to refer them to someone who specializes in ABA services, right?
Yeah, I think where we look. Oh, go ahead, Chris.
I was going to say, I just think another neat thing about this is a couple of visits I've been down, we spent a lot of time with local law enforcement. So we're really going outside of what our industry would be, right? So back in Pennsylvania, the only time I have contact with local law enforcement is unfortunately when they come to one of my programs to deal with an escalating child. And this program is really set up where we've made contacts with all of these wonderful police, and they're talking about how they're going to use this service all the time. And they talk about the struggles of when they pick up a kid at 2 o'clock in the morning, their option is to go to the ER, sit there with that child for sometimes hours until someone can hand them off. And that's taking them away from their other jobs and responsibilities. So they're just really excited about this. And I thought that was a really great kind of thing, something that I haven't dealt with in the past.
Yeah, I do want to go back to that, because one of the things that we didn't say is very early on, we had to rezone. And rezoning in a small town, because this is in the town of Fuquay-Varina, North Carolina. And to rezone is risky. And we originally didn't think we would have to rezone. And then the town came back and said we had to rezone. And so we really spent a lot of time with one of the Kidspeace business development staff at the time, walking the neighborhoods. I actually know all the neighbors. They have my cell phone. And did that intentionally before Kidspeace was really on site, so that they would start seeing friendly faces, have a contact, and hey, I've gotten calls if the lawn didn't get mowed in a month. I mean, I got those calls from the dentist office adjacent. But I think those relationships are going to go a long way to understanding and welcoming it. We made it through rezoning without an issue. So I think that bodes well for the community welcome. And so, Chris, your point well taken. I think law enforcement is very excited, and they've been extremely supportive from the beginning. School system is very supportive. So that's been really good.
Well, to take a kind of a half step back, you guys talked about a lot about the time. You know, the zoning was extra time. You advised at the end of the presentation, budget more time. So we had a question just come in from Ms. Brown. She asked, how long did it take to launch the program? If it wasn't for COVID, how long might it have taken? You know, and I'm gonna expand that to say everybody's got a different scenario they're dealing with, but you know, if the stars align, how quickly is it? And then what are some of the things that they're just going to tack on extra time that needs to be accounted for?
So I do have a kind of a comparison, which is really interesting. We as we said, we got the grant in early 2017. So that was a long time ago. And we bought the building not long after the grant, probably 6 months after we got the grant, 6 to 9 months after we got the grant. But in 2018, our legislature actually went in and gave us some reoccurring budget cuts that cut us very deep. And so, and that was the whole mental health system. It wasn't just Alliance. It was our whole, it was our sister organizations across the state. And we decided to put it on hold for a year. And so that really hurt. And we had done the roof, the parking lot, we had done the mold and asbestos abatement, and we sat on it. Kept it alive and maintained it, but we didn't do the complete renovation. So that really interrupted the timeline. When COVID hit, then it just accelerated. I mean, we would have wanted it open yesterday, right? We were getting calls from everybody and their brother in probably May of 2020 saying, how long will it take you? And so here we are through several other issues. Now, I have a facility for adults that we are in the middle of planning in Charlotte. And we got the, and that was using some ARPA funds that the county had asked us to utilize to get this up and running. The county actually had land they're going to build. And so the county owns the building, we don't. And we have selected the provider. We are anticipating the fall of 2025. And that's with a new build. So, you know, if the stars align there and we don't have another pandemic, we don't have, you know, a construction issue, you know, I think, you know, if you're looking at a brand new build, it shouldn't be more than a couple of years should be about right. And this is with land already identified. So, So that gives you a little bit of a comparison. We hit every possible barrier there would. I kind of joke with the architect that we'd christen it like a yacht, and we hit a bottle of champagne against the building once it opens, except that we're afraid something would happen. So it really has been a barrier after barrier on this one. I don't think most people will run into that.
Okay, so we had another question come in from Miss Miller. What is your staff client ratio for each facility in your mobile teams?
3 to 1. So the client to staff ratio is 3 clients for every 1 staff member. What is the actual staff to client ratio? On the behavioral health urgent care, we are staffed to essentially be able to provide, if everybody wasn't busy doing assessments or whatever they were doing, 1 staff member to every 1 client. So we are very, very well staffed for the number of kids that we will be serving.
Yes, it is pretty staff dense, and you could have 4 or 5 kids there in observation simultaneously. So you have to have staff that would be with them, and at the same time, you still have all the clinical activities going on in the background, right? So it is a staff dense program.
So we had another question about the partnerships, and it's prefaced with creating partnerships can create challenges. We're talking about merging cultures, workforce software, for example. What were the challenges? What were the big ones?
Actually, that's not the level of partnership we develop with the community providers. We build relationships. We share information across our systems. So what are some of the triage questions that the behavioral health urgent care or FBC may ask a client? That's something that one of the providers in the community asked me, so they want to know what kinds of medical conditions or behavioral conditions would we not be able to handle at our facility. And I most often tell them there are very few things that would rule out service at our facility. I'll take a person with a hangnail as quickly as I'll take a person who has a disorder where they're not nonverbal or unable to communicate with sign language. It's more about building the relationships than it is integrating any of our services whatsoever.
Okay, so how about between Kidspeace and Alliance? How about if we look at it?
Yeah. There is that, that they've had to adjust to how we construct a billing scenario. That's been as they're doing they're building out their EHR. So that's been some of the discussion as of late. We have almost been working on this so long, it almost feels like we're extensions of each other, like we talk to each other a lot. We have their team and our team planning open house activities. They actually have invited another state to come look at it because they're interested in doing something similar. We are very respectful in terms, I think, of knowing what Alliance's place is and what Kidspeace is. I have no desire to be on call for their people. I have no desire to tell Tammy how to run this thing. She knows how to run this thing.
You want to take weekends?
No. I have every desire, though, to see the needle move for our kids and families in a positive direction. And I feel very confident from the discussions we've had all along the way that that's exactly where they're headed. Of course, there's other things they're invested in as an organization, no question. but that for us is the biggest needle, and it's a value that I think we have in common that helps those discussions.
We've had a lot of open communication and it's ongoing. Internally at Kidspeace, we're meeting weekly on this project for the last couple of years. Sometimes they're half-hour meetings, but it's very well organized and all the ducks in a row. Alliance and Kidspeace have very similar missions, so we want what's best for the kids and the consumers. We're there for them, and there's a lot of folks too that at this level who our backgrounds are primarily in counseling and that field. It's very common, especially at Kidspeace. Our CEO is a great guy. He's got an MBA. A lot of other folks just have, like me, have our psychologists who kind of worked themselves up and figured out the business model of it. And that's very similar at Alliance as well. So you're always looking at it as what's best for the consumer. And I think that's why it's made this partnership even better.
Right. And part of the partnership also is understanding the expectations of the funder that you're working with. I've been doing this, as I said, since 2008, and I've helped stand up a couple of different facility-based crises. This is my first big lift on my own. I haven't been alone any step of this adventure, but as a director, it's about understanding what the MCO is or the funder is looking for from your agency, reading through the requirements for the service that you're going to be providing, understanding the general statutes for the state for which you are providing those services, building policies, sometimes from scratch, sometimes by just reviewing those statutes and the expectations of your funder, and then preparing for the world of red tape through the state and licensure process, and understanding that there will be bumps and bruises and times you'll need to dust yourself off through that process as well. So.
Yeah, and that's one of the things that we have struggled with in North Carolina, is getting through licensure processes quickly. It's slowed down. They are down-staffed like a lot of provider agencies, and so our CEO right now is receiving a weekly report from me on where we are in every. This is not the only project we have that is a facility. This is the only one like this. And so I give a report every week to our executive leadership, and he will advocate. And it has been doing some good, so that we'll keep that up.
Okay. You mentioned working with the MCOs. Could you give us a brief snapshot, how this is funded? And I guess what I would really like to know is, how does that conversation work? Like when you talk to the payers, is it just they look for something you deliver? Or is there a negotiation or outcomes? Can you leverage your good outcomes, whatever what they are, for a better deal? Just kind of a guidance for our listeners on, nobody wants to talk to the payers, but it's
who wants to
mandatory,
start?
Right, to happen.
It's a combination of everything. It really is. I know in a lot of our contract negotiations with MCOs and PA, we're showing data. We're showing why this service is needed. We're showing everything from, how the consumer is getting better in the service by different things that we're tracking. And we try to ask for certain increments of adjustments every year based on, everything that we're doing and adding to it. So, and reaching out when it's a new service, it's reaching out to that provider and saying, this is the service, here's our service description, this is what we're going to offer, will you contract with us? And that's how you get the ball rolling.
And it's about meeting the requirements of the funder when it comes to reporting, and some of the things that we track are recidivism, so repeated admissions in a certain time period, the time from door to dock, or so the time it takes a patient from coming through the door to see a provider and receive an evaluation, the number of services rendered in any given 30-day period. There are reports that go to both Alliance and to the state in regards to who walked through the door, how long were they there, where did they go when they leave?
Yeah, we have to report to the state on all of our crisis services, a standard kind of reporting format. And for us, we do a cost model, and they submit a budget to us, and we did a cost model to determine rates of the services. The facility-based crisis service in North Carolina has some standard rates. It's right around there. The behavioral health urgent care, like I said, we did a case rate that could have to adjust based on what we learn as we really move through the process. It may or may not be that we hit the mark on that. But I think that's the other part of the partnership, is that we need to be able to talk with each other about that. Because we kind of have, because Alliance really has so much investment in it, you know, they can use our information to negotiate with other funders. That's fine. I don't care. I mean, because kids are going to move around the system. We all want the same thing. And I think that's really important, that we make this a sustainable and replicable service.
That's the goal.
Okay. So that led to a follow-up question about the statutes in your state. Ms. Brown asks, how did you find out about them? Did you find out as you went along, or did you have to conduct research to gain that information?
Well, one of the adventures of working in facility-based crisis as a licensed clinician in the state of North Carolina is that you have to be credentialed with the North Carolina NC track system. And part of that is understanding the general statutes and service definitions. They actually quiz you on it before you are credentialed. So it's an experience, it's a level of knowledge and experience that you gain through both work experience and research. I will tell you that in preparing my policy deck for this facility, even though I've been doing this for multiple years, I spent considerable time in the general statutes, particularly in the ones that pertain specifically to facility-based crisis, to make sure that my policies are in line and actually oftentimes will contain almost exact wording from the statute so that they meet the requirements for the state.
And there's a lot done.
Sorry, Chris. I was just going to say, we're regulatory rich, let me tell you.
Yes.
North Carolina does not lack in general statutes and regulatory oversight. And so it's really, it is complicated. And a lot of this, as Tammy said, they've had to learn on, you know, by doing research, and we have been helping as much as we know and can help along the way as well.
Yeah, there was a lot done. You know, in PA, some of my regs are 2 pages. That's it. And then you get to North Carolina and they're 58 pages. And you've got to do a crosswalk to make sure every policy, and, you know, thinking about what I learned now and what I could have done before, I think Tammy and I would both say we would have gotten somebody else to write all the policies, because we've literally probably did 50, 80 policies and standard operating procedures, like just for months and months and months to make sure everything's aligned. So when we're ready to open, we can pass with flying colors.
Okay, well, we're coming to the top of the hour. Chris, Kate, and Tammy, I want to thank you very much for being with us here today. I want to thank everybody who joined us today, and I want to remind everybody that the slides and recording for this will be made available on the Open Minds website. And we're gonna talk about our upcoming. Chris, if you could advance me one slide there, please. Okay, so our next roundtable, if you want to join us, will be Thursday, February 2nd at 1 p.m. Eastern. Measurement-based care, the Aurora Mental Health Center case study, which will explore how Aurora is using measurement-based care and its outcomes data to improve time to remission and expand access to care. For a full list of our upcoming roundtables or to register for February 2nd, please visit us at www.openminds.com. Tammy, Kate, Chris, this has been really fun and very informative. And if we did not get to anybody's questions today, I will personally follow up with our speakers and find the answers.
Thanks so much for
Very much.
having us.
Have a great afternoon.
You too.